As part of the CME criteria, please be aware this is a CME accredited event. There are no commercial sponsors of this going rounds. Disclosures were reviewed and no conflicts of interest were found. And it is my pleasure to introduce Dr. Peter Yu. He's an assistant professor of transplantation immunology and the associate director of the surgical residency program here at Yale.
Thanks. Good morning, everybody. I'm going to switch over to my machine over here. And funny, last night, as we were enjoying the nice weather and the kids were out riding bikes on the green in Guilford, and a bunch of knucklehead dads and I were chit-chatting. We were talking about what I was going to be doing this morning. I told them what I was doing. He said, well, one guy said to the rest, he said, well, we should make sure that Peter thanks the Department of Urology for sterilizing most of our friends. So, of course, the other one was quick to point out that you still have a lot more work to do in our neighborhood. So we're going to talk this morning about burnout and well-being among surgical residents. It's a topic that I've been working on for about 5 or 6 years now. I should tell you how I came to the topic of burnout and wellness, or well-being as it's called among the surgical educators. About 6 years ago, I joined the faculty, and Walter Longo assigned me to this topic. He said, Peter, there's this thing called wellness. We have to do it. Do it. And I said, okay. And then so we've been looking at it, thinking about it, and studying it, working on it ever since then. I will tell you that wellness, when I first heard the word, struck me as an odd term for surgeons to be using. Burnout seems to me to be a pretty good selection tool, survival of the fittest. But as we're going to talk today, these are really not useful distinctions in the realm of surgical educators who are creating careers for our trainees. So of course I have no financial interests and almost no actual data. Some basic premises I want to go through is that habits that we acquire during residency, whether good and bad, they tend to extinguish slowly. And this is getting up early, making sure you round on your patients before you leave the hospital, flipping through labs on Epic before you go to bed at night. These are the habits we want to inculcate in our residents. Those are the good ones. But I will also offer that bad habits tend to extinguish slowly just as well. And physically, mentally healthy and contented trainees will tend to perform better, establish habits of a long, healthy, and satisfying career. They're less likely to burn out, and we'll talk about what that means during their careers. They'll improve the workplace culture. They'll attract higher quality trainees to the field and sustain the future surgical workforce. As surgical educators, what, after all, do we want for our trainees? And I'm sure Dr. Shulam has a slide that looks something like this. The tripartite mission of the academic medical center, or if you're at the Mayo Clinic, the 3 shields of training. And this is, of course, first put forth at Johns Hopkins. I put this here for Dr. Shulam's benefit, actually. But at the Johns Hopkins, William Stewart Halstead went to Germany, came back from Germany, and created this for Deutsch or Germanized training program where he would admit 8 interns with the plan of having 1 house surgeon or chief at the end of those, at the end of 5 or 6 years. Getting rid of the rest of them. And of course, this led to what we in surgery called the pyramidal system. And the pyramidal system was the basis for surgical training, and it persisted until the 1990s or so. Progress up the pyramid was not only through prowess and knowledge and skill, but also by cutthroat competitiveness and demonstrations of devotion to the profession. So just as the construction of the pyramids left many casualties, so did the pyramidal system in surgical training. As a result, our trainees tend to endure physical, mental, and emotional hardships. There are burdens on their families. There are lost personal opportunities, and there are abandonments of outside interests. Nobody in the room is unfamiliar with these concepts. Nobody. But what do we actually mean when we're talking about burnout? So if you'll type burnout into Google, and this is what you get. It's a reduction of a fuel or substance to nothing through use or combustion. Now, metaphorically, that kind of sounds about right. And then physical or mental collapse caused by overwork or stress. And what we hope is not the case is the third one, the informal definition, a dropout or drug abuser, okay? But all 3 seem to have some applicability to the notion of burnout in the professional workplace. And it's important to realize that burnout is more than just working hard. It's more than just using your fuel up. And Freudenberger, who's a psychologist in 1974, described it as a state of physical, mental, and emotional exhaustion. And Maslach and Leiter in the more recent era have been talking about what are the major contributors to burnout. And they're the two who have really contributed most to the science of burnout in the medical profession. It's work overload, lack of control, values conflict, insufficient reward structure, and unfairness, followed by breakdown of community. And when you think about the life of the resident, the life of the young surgeon, the life of the young urologist, this is really what we're talking about, right? These 6 dimensions are clearly areas that trainees can identify with as detractors from quality of life. So, as I mentioned before, many have viewed burnout for a long time to be just a case of selection of the fittest. Those who don't burn out will succeed. Those who do burn out can go do something else. I would say that it's not necessarily an appropriate way of thinking, because burnout does select the fittest. The idea that burnout does select the fittest, well, it just has to do with the idea that everybody works hard and that there are unrewarding tasks unrelated to learning, and then your gratification is dramatically delayed through that process. And in the process, you also lose the ability to derive self-worth outside of the workplace. You work all day, you recover from your work day at night, you go back and work the next day, if you get home that night at all. And so you hear a few quotations from other surgeons. During residency, the only thing I was good at was being a resident, and I wasn't even that good at that. And burnout selects against the weak, and for the strongest, most devoted, the most single-minded. Now that's conventional wisdom, right? That the least successful and unfit residents will tend to burn out, and the fittest will survive. Working hard, performing poorly, they've got their career in surgery, but they find that it's not worth the hassle. They're not getting the bang for all the effort that they're putting into it. This leads to attrition and burnout. But it's important to realize that the most successful residents are also at risk. So burnout is not necessarily correlated with failure. Burnout and success travel independently. Dedicated and conscientious and responsible, motivated residents who tend to submerge themselves in their work, give their all with nothing left to give. They abandon other sources of joy and pleasure to the general effort of trying to succeed as a resident. They derive inadequate reward for their work, and then they find that their cost-benefit imbalance also is off, leading to burnout, dissatisfaction with the career. So paradoxically, burnout and dissatisfaction afflict highly successful trainees as well, not just those who are performing poorly. And it's important to understand at this point that the culture of the conventional health study and surgical training really does promote burnout in and of itself. I'd like to argue that the cutthroat competitive training culture that we're familiar with is obsolete, and the strong resident versus weak resident distinction is really not that useful. Training now is rectangular. You admit as many interns as you plan to graduate, and the vestiges of pyramidal training still, but the vestiges of pyramidal training still tend to harm trainees and the profession overall. So how do we measure burnout? We use, in most situations, the Maslach burnout inventory. It's fairly well agreed upon. It's a fairly easy to administer tool. It's a 22-point survey designed to test things like emotional exhaustion, depersonalization, and reduced personal accomplishment. It's really the gold standard instrument, though there are others that are easier. None is really quite as well agreed upon as the Maslach burnout inventory. And as the result of this rubric, there's been quite a bit of literature that's been released about this topic, trying to quantify burnout and other dimensions that are the result of it. Stress of residency, recognizing signs of depression and suicide in you and your fellow residents. That's from NYU. Leon Pachter led this effort after the very tragic suicide of an intern in their program. Work-home conflicts have a substantial impact on career decisions that affect the adequacy of the surgical workforce. And you can just substitute the word surgical with urological or surgeons for urologists, right? The prevalence of alcohol use disorders among American surgeons. 1 in 6 has an alcohol use or abuse disorder. And avoiding burnout, the personal health habits and wellness practices of US surgeons. And we're going to focus a little bit on the work of this individual, Tate Shanafelt, who was recently attracted away from the Mayo Clinic to to Stanford, where he's now believe it or not, the chief wellness officer for the medical system. At the Mayo Clinic, Tate and his colleagues were working on this institutional culture to prevent burnout. And there they've achieved one of the lowest burnout rates for all physicians nationwide. And it's about 36%. The YMG number is somewhere around 62%, end of 2016. Interestingly, surgeons tend to be slightly less burned out than other specialties. So the American College of Surgeons sent out a survey to about 7,000 responses and received about 7,000 responses and did a qualitative survey of burnout and low mental quality of life. You can interpret that however you'd like to, but they developed an instrument that really just correlates these two, burnout and low mental quality of life. They found that men were less likely to be burned out. You were less likely to be burned out if you placed greater emphasis on finding meaning in work, focusing on what is important in life, maintaining a positive outlook, embracing a philosophy that stresses work-life balance. You were more likely to be burned out if you had been more than 12 months since your last PMD visit. There was, of course, a significant overlap between contributors to burnout and low mental quality of life. Now, many in this room will probably have seen or been emailed this figure, right? We are familiar with this figure, developed from the physicians of the 3 sites of the Mayo Clinic. This is about 5 or 7 years old. And the 2 dimensions that we're looking at on the X is the percentage of burnout, okay? And on the Y is satisfaction with work-life balance. This is all about qualitative, subjective reporting of how well you're meeting your expectations for yourself, right? So, you know, your eye immediately goes to the bottom right over here. Urologic surgery, the percentage burned out is somewhere in the 60s. And it's of all the specialties queried, the lowest satisfaction with work-life balance. These are Mayo Clinic staff, 3 sites. I mean, that's a pretty heavy chuckle there, Preston, yeah. So, I mean, it's pretty shocking. But what is it about the way these individuals are trained here, preventive medicine and occupational med? What are their expectations for their careers as they're at the outset of their careers that leads to greater satisfaction? Do they have a better understanding of what the demands are going to be? Do the neurosurgeons have a poorer understanding of what the expectations are going to be? Are they dissatisfied because their career ended up being different than what they were expecting? Or is it just that it's a brutal career? It's hard to say. But just to say that there are a lot of dimensions that feed into this axis over here. This, the x-axis, tends to be a little bit more quantitative than the y. So what are the causes of burnout? Well, we talked about lack of control. In the eyes of a resident, this is the call schedule. You don't get to decide when you show up. You don't get to decide when you take a vacation. You know, you've got to have Mother's Day brunch with your, you know, you've been up all night. You've got to get home to take a shower to go have a Mother's Day brunch, but your attending decides to round an hour late. You missed Mother's Day brunch. And you don't have control over which assignments, which cases you get assigned to and whom you work with. There's a values conflict between the organization and individuals in some cases. Of course, there's insufficient or delayed reward. There's delayed autonomy, salary, prestige, and sometimes slow skill development, though not with your residents. There's work overload, which needs no explanation. There's unfairness. There's favoritism. There's inconsistency between spoken and written evaluations. And we have a breakdown of community. We're working on this system-wide, right? Uncivil behavior, verbal abuse, competitiveness, and antagonism with other services. These breakdowns of community. Who in the room hasn't at some point flipped out in the emergency room at 2 in the morning? Basically, that's what we're talking about. All these things contribute to the idea of burnout for our residents. Some of the language that's used to describe their experiences of burnout are on the screen here. Declining health, missed family wedding, gaining weight, finances in shambles. I mean, these are not the words. This is not the language of residents who are thriving. So we have this tug of war, this give and take between burnout and wellness. The various descriptions that people use to sort of to describe the different dimensions of both burnout and wellness. To quantify it a little bit better, we decided to study it because we really didn't know what we were dealing with. We did a small pilot study in our own residency program, but so as to generalize a little bit better, we undertook a study a few years ago through the New England Surgical Society. 10 of the 19 New England programs participated, about 50% participation, and the data was collected 2 years ago now. We looked at a few different dimensions. The first one was health maintenance. How well do our residents look after themselves? Do they have a primary health care provider? And we know that if you don't, you're much more likely to experience significant burnout. Do you have illness-specific follow-up? If you were supposed to get a follow-up of one test or another, did you go seek that follow-up? Do you have a dentist or hygienist? Is your dental care up to date? Have you had dental care in the past 2 years? And crazy enough, is your vision prescription up to date? What's your exercise program like? Do you exercise enough to stay fit, whatever that means to you? Well, shockingly, about 30% said no. We've talked about weight. Before residency, my weight was above my ideal body weight. Okay. Or about 3% were below their ideal body weight. And most were, these are 25-year-old healthy people. They were close to their ideal body weight. But since starting residency, what's happened to their weight? You can guess. Stayed the same? Okay. Increased and they're happy about it? 2.5%, right? That was that group that was below their ideal body weight, I'm guessing, right? So their weight increased and they're happy about it. Or their weight decreased and they're happy about it. Good job. All right, they're decreased and not happy, 8%. But look at this group, increased and they're not happy about it, right? So we talked about fatigue recognition, and we administered the Epworth Sleepiness Scale. It's used by sleep doctors to talk about people with sleep disorders to see how likely they are to fall asleep in appropriate times during the day, right? So there are 8 different questions, and you're meant to answer 0 to 3 how likely you are to doze in each of these different circumstances. Stopped at a light, sitting and reading, watching TV, sitting in a public place, passenger in a car, lying down in the afternoon, having a quiet conversation, or sitting quietly after lunch, and importantly, after lunch, no alcohol. So normal sleep gives you an Epworth score in the 5s. Insomniacs who don't sleep are extremely unlikely to fall asleep inappropriately, of course, so they have a lower score. Sleep apnea with interrupted overnight sleep gives you a predilection for excessive daytime sleepiness. And of course, narcolepsy is 17.5 is up there. So the higher the number, the more disordered your nighttime sleep, and as a result, the more disordered your daytime sleep. Residents in the survey came up here. So somewhere between moderate sleep apnea and narcolepsy, okay? Daily finances, long-term planning, and the burden of debt. We talked about the personal finances. It's say, is your training stipend adequate to cover your living expenses? Now here in New England, here in New Haven, we pay our residents at the AAMC 75th percentile. So so we track somewhere with DC and Boston, not quite New York and San Francisco. Our day-to-day finances are in order, 3/4. But 3/4 also worry about their finances. Comprehensive financial plan, individual life insurance policy, individual disability insurance policy, a will or estate plan in place, and who here has maximized their workplace retirement savings? Now, everybody in the faculty, by the time you're on the faculty, you've had it beaten into you that you've got to maximize your 403B and get your TIAA ramped up. But less than half of our residents are taking advantage of hospital matching for their 403B, which is very unusual. A, it's very unusual that a residency program has a 403B program. B, it's unusual that the residency has matching for their 403, but less than half of our residents are taking advantage of it. Let's talk about their financial debt, their educational debt. So about 1/5 have over $300,000 in educational debt, right? So between 200, so over half have over $200,000 in debt. Okay, that's where our residents are these days. So if you take $250,000 at 5% interest, or amortized over a 30-year loan, it's about $16,000 a year in payments if it's on a flat payment schedule. If you look at a PGY3 salary, which is $66,000, and they net about $43,000 a year. So annually, their student loans, if they're paying at a flat rate, ends up to be about 35, 40% of their annual salary. So it's a burden. How are they doing? About 13% are in deferment. We've got 1% in default and about 10% in forbearance. That's a problem, right? Only about half are making scheduled payments. And of course, about 20% have no loans at all. I was told that in order to communicate better with residents, you should jazz up your slides with emojis. So I'm doing it. Pat, yeah. This is from 10 surgical programs, community and university throughout New England. But it's just about uniform. For our residents, there were really no outliers in these figures.
Loan forgiveness programs that exist now. Shocking to me that more than 20% of the residents aren't taking advantage of it.
Right.
That could be a decision that's a six-figure take.
Yeah, absolutely. Absolutely. The work environment. Well, the good news is that the vast majority of our trainees enjoy training. They enjoy coming to work today. They enjoy coming to work each day. And they are friends with their co-residents. But they do find that the demands of the job interfere with their ability to manage personal matters. Most do find that the well-being of the residents is important to their PD, and that down here we have a problem, right? The well-being of residents important to attendings, less than half. So what's their stress like at work? You know, most will report moderate, but 15% say severe or extreme. And 3/4 will say that their general well-being is negatively affected by work-related stress. So as the result of the New England Surgical Resident Well-Being Survey, we defined these areas for improvement: personal health management with regard to exercise and weight gain, health maintenance, fatigue management, financial management with regard to planning and debt management, and the work environment. We think that 70% enjoying coming to work, that's not enough. Right, and 40% finding that residents' well-being is important to attendings. It's not enough. We can do better. We ought to do better. So Houston, we have a problem, right? What should we do? I think that the first thing to do is, accept it. This is the way it is. Whether or not you think that wellness is appropriate for surgeons to talk about, for urologists to talk about. I mean, someone told me, Peter, wellness is for pediatricians, man. And I found that more pejorative to surgeons than, of course, I did to pediatricians. So I think that the fact that we're having the discussion in the room today is an important first step. So what should we do? Do we advocate a nanny state, get everybody a participation trophy? Should we just lower our standards and say maybe everybody should only work 8 hours and you should graduate with 400 cases? See how that goes? Well, I would say no. You know, anybody remember about 2011 or so, Jeremy Lin, this Harvard alum who was scoring 35 points a game for about a month and a half straight or something like that. Remember this guy? So Linsanity, right? Around that time, so every medium height Asian man with an expensive Ivy League education briefly thought he could play in the NBA. I will say that just because you want to be a surgeon doesn't mean you can or should be a surgeon, right? Or substitute the word urologist. Specific mental, emotional, physical traits need to be present for success to be achieved. And no selection process is perfect, and some attrition is healthy, right? Let's just at the outset accept that, right? I'm not saying that we should lower the bar, that we should let the stragglers, the ones who are really suffering, who are doing poorly, we should not keep those people in the profession. You don't do them a favor, you don't do the profession a favor. So let's accept that attrition is normal. And I'm not advocating that we lower the bar. Quite to the contrary, I think that we're talking about doing better by one another, doing better by ourselves so that we can each perform at our best. So we're actually raising the bar so that we don't have excessive daytime sleepiness, distractions from stress, internecine battles among us. Burnout reduction has to become a priority to institutional, departmental, and programmatic leadership, right? So the idea is to protect the integrity of clinical care and the educational experience at all costs. We can't sacrifice those for well-being of our practitioners. There's some dollars that need to be set aside for this. There's some measurement, evaluation, and rebalancing of the service and education ratio, right? All SCUT, no OR makes for a very dull residency. You have to convey appropriately due respect and dignity to residents. The days of accepting and permitting bullying of our residents is over. We have to examine and renew the workplace culture and to identify, reward, and promote affirmative role models within the faculty. So let's just talk about our Department of Surgery's approach to trainee well-being and how we've taken on the idea of burnout reduction among our trainees. First, again, I want to reiterate that habits acquired during residency tend to extinguish slowly. Surgeons must be physically and mentally healthy and fit to take optimal care of patients. And we must be interested in the health and well-being of all of our members of our professional community. And those are our marching orders for the Surgical Residence Wellness Committee. It's led by a group of residents, and that's a picture of my own waistband that was emailed to me by Justin Cohen, who many in the room will remember. So we were interns together, and one night after he handed me all his pagers to carry in addition to my own, he took a picture of the waist. So it has to be identified as a department level priority with support from the chair, from the med school administration, and from the DIO. We have to optimize satisfying learning experiences and dilute the less educational services, okay? The idea that one intern can cover the services is going to be appropriate in some circumstances, but not all. Let's face it, the care of the patients today is far more complex than it was 10 years ago. There are virtually no patients admitted from home the night before to be pre-opt for a bowel cleanse before their prostatectomy. It just doesn't happen these days, right? I mean, or does it, right? So there's very little babysitting of non-acute patients happening. The level of acuity in the hospital has gone up dramatically in the past decade. The residents are working all night. So we have to think about make sure that they have satisfying learning experiences and that it's not all just busy work. So we have to try and maximize OR time, especially for the PG 1s and 2s. These are racehorses. The racehorses have to run. We have to minimize night float. It's identified nationally as a major detractor to well-being, and maximize the utility of APPs. APPs are better at many of the tasks to which the residents are assigned. They provide better care, they provide better longitudinal care, and they're actually better at teaching the residents some of those tasks. So better to offload a lot of tasks on the floors to the APPs because they can do it better than the trainees can. It's safer for the patients. And then we have to examine and repair the training culture and climate. Appoint an ombudsman, have an external review of the training climate and culture, and then really address abusive behaviors, etc. We have to talk about fixing broken windows. And these are the last two things are the things I'm going to talk about for the rest of the talk. What are the options that we have to really invest in people's well-being? What can we do here? How are we operationally getting to this point where we're working on fixing the broken windows of residency? That's coming up in a couple slides. First off, I'm a transplant surgeon. I think through a leukocytic lens. I think of residents like mast cells. Why do we have to decrease all these? Why is it important to improve their workplace or how they spend their workday? Because they're like mast cells. And an unprimed, unallergic host, a mast cell is just hanging out. A cat walks by the host, the non-allergic host, nothing happens. They've got plenty of threshold between the stimulus and degranulation, right? But in the primed, highly allergic mast cell, you get some stimulus that should otherwise be irrelevant, and that mast cell degranulates, right? So you get IgE and you get all the cytokine release and all that nonsense. But the analogy to residents is that a resident who's doing well, who's sleeping, whose finances are in order, who made it to their PMD, who got to see grandma at her last birthday, right? That resident is going to go into the emergency room at night and have some irritating experience and walk away from it without having degranulated. But the stressed, financially burdened, under-rested, otherwise irritated and primed mast cell of a resident, when that person experiences what should be an irrelevant stimulus, they're going to degranulate, right? And that's the difference between handling the workplace environment of the resident and not handling it, right? So in New York City, Rudy Giuliani came into the office, and you can say what you want about Rudy Giuliani, but it's pretty difficult to argue that it wasn't cleaner after he was done being mayor. Let's just say that. Argue everything else, but it was cleaner, okay? Times Square had less garbage in it. But the idea that he brought to New York City was that if you fix the broken windows, if you patch up, if you scrub off the graffiti and you handle the minor quality of life crimes, like people urinating in the street and jumping over turnstiles in the subway, then it would decrease the overall sense of lawlessness. The overall sense of lawlessness would lead to less commission of larger crimes like theft, rape, and murder. And so Rudy Giuliani's administration went around fixing all the boarded up buildings and demolishing them and really attacking all the little quality of life crimes. And so we've done the same in our residency. We've tried to address the broken windows of the surgical program by addressing the little things that contribute to disorder and nuisance, to reduce the overall sense of chaos that leads to crisis and breakdown of professionalism. We try to reduce the trainees' false belief that nobody cares. So we try to pay attention to small matters. What are the broken windows of the surgical residency? And I hate to say it, but we've had to get involved in things like managing their call rooms, making sure that they have enough scrubs, that their white coats get laundered, that their OR lockers are handled appropriately, that they have access to the supply closets, that their EMR, pagers, and phones, that they have enough tech support for those things. The problems with the ED. There are a lot of problems between my residents and the ED, and making sure that they have enough food vouchers at all the sites. Parking. Everybody in this room is aware that parking for our residents is a problem as you go between the two campuses of Yale New Haven Hospital. But the residents don't have the ability to solve those problems on their own. They're transient and they're powerless to fix those problems. Those problems have to be fixed at the level of the faculty. And so the chair, the PD, the APD, the program coordinators, Steve Hewitt, and your partners like myself and Walter Longo have to be engaged, willing to engage at high levels on behalf of the residents to fix these problems, to decrease the overall sense of chaos and lawlessness that leads to the more significant breakdowns of community and professionalism. So this is the flyer for House Staff Appreciation Week 2 or 3 weeks ago. Okay, you got massages, yoga, ice cream, Rana Audish, that sounds great, and drinks at Elm City Social, okay? But you know that feeling when you're on vacation, you've been on vacation for 6 days, it's now Friday of vacation, and you decide to check your Outlook email or whatever it is, and you look at your calendar for Monday and your stomach kind of flips. You say, boy, and then Sunday night you land, you're home, you get in bed, and you wake up Monday morning, I'm refreshed, I had a good vacation. And by lunch Monday, you feel just as you did Friday before you left for vacation. That vacation worked while you were on vacation. But once you get back to work, if your work circumstances haven't improved while you were away, it's going to be as problematic as it was the day you left. So I will say that yoga, massages, they may help bring your blood pressure down for the moment. But really, I think the strategy is to fix the initial insult. So we tried to bring about a pretty wide cultural shift for our department's priorities. So we have program-sponsored resident-led initiative to improve general health and well-being for our residents. They came up with a residents healthcare Rolodex. They found out we've identified some PMDs, dentists, mental health doctors who are willing to engage with residents at weird hours on the topics that affect residents. They have group activities for exploring regional culture and recreation. We have physical activity groups like hiking and cycling. There's some people participate in intramural soccer. We're trying to have healthier food options at conferences. We have department-wide recognition of families and accomplishments, and we have Q6-month specific aims for well-being. I will say that none of these things is, except for the residents' healthcare Rolodex, none of these things really gets to the issue of what's the resident's culture like. I think that importantly, we're trying to normalize the idea that if there's nothing else going on, if clinic is tended to, if cases are covered, that it should be okay for a resident to leave the hospital to go see their doctor, okay? It should be okay to get your eyes checked, visit with your lawyer, and do those things. That residents don't necessarily need to forego those things as acts of demonstration of devotion to the profession, of how tough they are. They're willing to forego all their own needs to work harder. I don't think that it's a germane conversation any longer. We've also done this thing called the Yale Active Surgeon Initiative. We're trying to see who's moving and keep our residents moving because we're trying to figure out how to keep the weight gain to a minimum. So they all have hospital-issued iPhones. This is these are 2 nights of Molly Friedman Weiss. She got to work, it started recording about 6 a.m. and then at midnight it stops recording. And she traveled 13.1 miles, 23,000 steps and 40 flights of stairs. This is not by any means the record. Jolanta Gareca in 30 hours didn't take an elevator once and climbed 72 flights of stairs. So we have resident teams. There are meant to be semi-annual prizes, but we haven't figured out what we're going to give them yet. Pizza party, yeah. Pizza and cake, yeah. And then it's hard to see, but we have this little inventory, this checklist of, and they don't give it to me, they don't turn it in, but we hand it out to the residents. We give them this checklist and have them look, are they thinking about their nutrition? Do they have a plan for communication with friends and family? Do they have time for family? I mean, this one is, I'm not a pet person, but someone even included, do you have a plan for pet care? Now, is this the usual dominion of a surgical program director? And I don't think so. But these are the things that the trainees have identified as important to them. And whether or not we like it, whether or not we think it's relevant, this is what the people who we're training think is relevant. And so it pays some dividends to pay attention to it. I will say that you know, they got together and came out to Guilford for a hike. You know, that's my second of 4 kids down at the end. That's not a very small surgical resident, and it was well received. But does this fix the problems that we have in the surgical workplace? No, it doesn't. Does it make them a little more collegial? Do they get along a little better? Have they blown off some steam? Sure. But does this fix those broken windows? It absolutely does not. So the results of this effort are entirely unknown, right? Are they living better, balanced, and happier, healthier lives? Truth is that I don't know. And we're just trying to figure out what the problem is, much less proclaim that we have any correct solutions. So the idea here is that burnout among surgical trainees and urological trainees has to be reduced. There's no way around it. We try to optimize fitness and performance. We try to train surgeons to have long, healthy, and satisfying careers so that we can secure the future workforce and continue to recruit the best and the brightest to our fields. The profession has to reject the status quo and hold ourselves to higher, not lower standards. I'm very grateful for your time and welcome any questions.
Do you have any information or have you queried the residents on what they think would make them, would increase their wellness? I mean, what, in terms of, I mean, I see some of the things that, I mean, if you were to query these guys out there, I mean, what would you think would be at the top of their list?
I think that the two big ideas is that, number one, that their education matters and how their education is constructed, that they walk away from the experience at the end of the day feeling like that their time was well spent and it was respected and curated in some way, that it wasn't ad hoc and not cared for. They deserve to be valued. They believe, and we agree, that their work, their effort, their intellect deserves to be valued. I think that a lot of the miscommunication that happens that leads to breakdowns of professionalism and well-being and eventually leads to burnout is that people don't feel valued for the work that they're doing. Secondly, I think that the trainees, when you talk to them, there's so much going on. They're pulled in so many directions that they're unable to tend to the things that from which they're able to derive some meaning as a human being other than just work. So if there are things that they need to do to keep themselves sane, even if it's just go for a run, if they can't get there, they're way behind the eight ball. So I think that that nowadays residents really do seek something else outside of being a resident to keep themselves grounded in reality, because the idea that you can get all of your self-worth from being a resident doesn't actually fly. That's my take on it, but I mean, I'm not in their minds. That's my interpretation of it.
Thanks, Peter, for a great talk. I just have, I guess, there are two comments, and maybe you can add to it. One is a minor comment. William Halstead was a cocaine addict.
Of course.
And I think everybody should know that historically, but he still functioned. I don't think he was being abused as a resident. I think he just figured out these anesthetics and he tried it on himself and he became an addict. The second point that I want to make about, which is not directly, but it is directly related to this topic, is who pays a resident's salary and the problem ongoing right now for residency payment in the graduate medical education budget within the Medicare, because you guys are paid by the government. So you don't realize what's going on, because there's advocacy going on right now to protect training money coming out of Medicare, because they want to cut this completely out. $17 billion is what's spent on resident. So I actually asked the residents, how would you like it if we don't pay you anything and you have to do the same? There's been some models floated that what's going to happen if the government says, hey, you guys figure out how to pay for the residents, goodbye. This will be a minor, this will be like nothing, because if you can't get paid, that's the ultimate lack of wellness, right? So believe me, there's, even in urology, I'm sure in surgery, there's every year the advocacy in Capitol Hill, GME comes up. And it's like, how do we protect, because it has to increase, right? Your salary has to increase every year. You can't, even if you're just at flat rate, you're gonna go down. So this is another area which I think is sort of related to this, is undergirding, because we are trying to say, hey, this is educational process is American medicine, and you have to educate trainees coming out. And yes, we have to be concerned about wellness and everything. But if you have no money, you have no wellness.
Absolutely true. Absolutely true. Present.
Peter, thanks. That was a great talk, very informative. Dr. Kenny and I were just chatting a little bit, and there is definitely a shift in perspective from sort of the older trainees or sort of older surgeons. Have you looked at all in terms of sort of alignment of goals? I mean, so this is a change. Like, we didn't have this when we were residents, like sort of the wellness movement. Implementing these kind of changes and activities for the attending staff, or for people, like, because we don't speak this language, we didn't have this, we may still not be doing this in our lives as attendings. If sort of there was a move to do that for the trainers, would that be easier acceptance to do it for the trainees?
I think that it's hard to say that it's going to work. I'm skeptical that these measures will work to change the outlook of people in our generation and older. I think that if we can inculcate the right habits and right values in our current trainees, then it'll be better for their generation and the following. There is a tremendous amount of work, and our chair just came back from the AAMC, where she was talking about culture of wellness in departments of surgery for faculty, not talking about the residents. I think that the residents have their own defensive line that's working for them at the moment. But who's looking out for the well-being of the faculty. Even in our own institution, Ron Vendors, as a result of the workplace culture and value survey or whatever it was that we all took a few years ago, Ron is leading a small group on which I sit, looking at how we can fix the problem of burnout among YMG practitioners. 62%, it's way, way higher than national norms. You know, national norms are sort of in the low 50s, but YMG's in the 60s. It's a problem for our workplace. It's a problem nationally, and it's really about. I think it's really about thinking about culture. You know, a very dear friend of mine talks about the plight of the 40-year-old surgeon, who the plight of the not the 40-year-old virgin, the 40-year-old surgeon, right? The 40-year-old surgeon who didn't party a lot in college, didn't take advantage of all his social options, worked hard during medical school, missed a few weddings down the road during residency, you know, missed a funeral or two during residency, and has been kicking the can down the road with the expectation of gratification when it became staff. And it just didn't happen. And looking back at those training experiences and thinking about, well, all those missed opportunities, and were they worth it for this career, which is satisfying, but still is not ultimately satisfying. There are still things in life that you need other than doing right by patients. And so, like many, you know, he bought some fancy cars and started a woodworking shop in his basement. There are people seeking these kinds of, seeking meaning in their 40s because they just didn't find a way to do it in their 20s and 30s, right? So it's an early midlife crisis.
You know, I would argue as well that if you really want to correct the problem, you got to go long before residency. I mean, I think if Yale University wants to correct it, it starts with college, it starts with getting into medical school, the stress of medical school, residency, the length of training, all of those things that start way before residency. And they come into it already with a lot of those things set up, and we kind of perpetuate all of that. So I mean, I think if Yale University wants to address, you have to address it long before they get to residency.
I think you're right. I think you're right.
Is there any push to kind of teach the senior residents how to kind of manage the junior residents with a certain level of appropriate demeanor, things like that? Because my sense is that there's certain, you know, as you come up the ladder, if you were treated poorly as a junior resident, there's certain people that don't necessarily treat their junior residents appropriately and don't necessarily kind of set up the appropriate status to go home at a reasonable time. You don't want to turn down your chief resident and say, I've been working 36 hours, I got to go home. You know, that's kind of frowned upon. So is there a general trend in surgery or otherwise to teach the residents how to treat themselves better?
There is, and even in our institution, we're working on things like harassment and bullying in the GME office, department chairs, YMG, professionalism. You know, Al Friedman, Steve Hewitt. It's a big thing. We don't have a consolidated approach to it yet. I'll tell you though that I've learned more about that. I've learned more about handling bullying and how I would have addressed the malignant chief resident in the past couple of years for my kids than anybody else. In second grade, my kids have this language. They say, ouch, stop. If someone's being mean to them, they put up their hand, they say, ouch, stop. They're taught that from the social worker in their public grade school. They have this idea of not just being a bystander, but being an upstander, so that if one child is bullying another, then the third party stands up for the bullied child. And you know, this is language that we didn't have in the 70s and 80s growing up, right? Well, when I was a kid in second grade. But these ideas I think are coming too. The idea that bullying is a thing, right? It's not just a thing for second and 10th graders. It's also a thing for surgical trainees, urological house staff, and it's even a thing in departments between full and assistant professors, right? So I think as a profession, bullying has to be acknowledged. I think that the university is doing something about it, The House Staff Office is doing something about it. We'll see if it works.
There an association between having a spouse and kids and wellness? Because on one hand, it's nice going home to someone, but on the other hand, it's a lot more responsibility.
Sure. So we did a survey of program directors of surgery about 2015. A Yale medical student of mine wanted to become a surgeon. She says, but is this going to be, will it be a problem that I plan to have children? So I said, I don't know, let's study it. So she circulated a program director survey across the country, had about 180 different program directors reply. And one of the questions was, does having a child negatively affect the trainee? And then how does having a child affect the trainee's overall well-being, number one, and overall performance? For men, program directors said that their male residents' well-being improved when they had a family and children, that their performance was neutral. For women, they said that all program directors said that their female trainees' well-being decreased if they had a child, and the performance also decreased. Right? That was the perception of the program directors. Whether or not it's true is arguable, right? Of course. But that's the perception of program directors. So yeah, so it's split by gender, I think.
So, and those program directors, were they predominantly men?
Predominantly men.
Okay. So I just wanted to point out some of the wellness initiatives that that are happening in the department for the residents that, particularly over the past year. I don't know, Kristen, if you want to comment. But in particular, addressing Stan, your question about, leadership training. So Kristen has arranged for the incoming chiefs to do some leadership training.
So for the past 6 months, we've been taking on some of these initiatives from the wellness standpoint and really looking at 8 different dimensions of wellness to address Stan. One thing that we're doing is looking into the ACGME Leadership Conference. Apparently from that level, they have programs that you can come in that we send our rising chiefs to in order to teach some of these leadership skills that you're talking about that are not embedded in the training. We've had one of our rising chiefs attend, and we have another one coming up in June. And I'm hoping that will kind of pay off in dividends, both for them personally and professionally, as well as what they can bring back to the program. And I've been working with the GME office and thinking about how to integrate that at a larger level than just our department. There's other things that we're doing with physical wellness. I think I definitely want to embed some of the things that Dr. Yu is talking about and how that could help really integrate into the fundamental part of what we're doing. But there's a lot of these initiatives that we're excited about and will continue through the next few months.
2-day exercise program is part of the timeout before we start our cases from now on.
Love it.
But
yoga.
But I mean, seriously, leadership, I think there are 2 parts to leadership. One is leading, but the other, if someone has had kind of a poor experience as a junior resident, just to teach them that is not necessarily the way you have to treat your underlings, that there is a different way to treat junior people and show them, give them what they need to some degree. I mean, look, you still need to do the work, but every resident needs something different. Some need to go home and be with their family a little bit. Others need to get an hour or 2 during the day of sleep, so just recognize that from a chief level to, be able to address that personally.
The residents, you guys remember Mark Maxfield? So Mark worked with me on a lot of these things when he was chief resident. And he said, Peter, I guess I got to go see the doctor. I haven't seen the doctor since he had a physical to do a sub-internship when he was a medical student. He had to get a physical in order to apply for a sub-internship to prove that he had some certain vaccines and things like that. So he did that. And so there he was, a graduating chief resident. He just had a child. It's March of chief year, his first physical in 8.5 years. And he finds out that his vision is a diopter and a half out. And probably the reason he's unable to operate without loops on is because he just needed glasses the whole time, right? And he just hadn't been to a PMD who put him up next to a vision chart in almost a decade, right? And here we are, that's a graduating chief resident. He's a CT surgeon now. But it's hard to believe, isn't it? I mean, that the culture of our training program would permit that to happen.
I'd say if you're the control group of 120
Probably similar, yeah. But I think that the stakes are higher for us. You wouldn't see an FAA licensed pilot with uncertain vision, right? You wouldn't see an NBA player who hadn't seen the PMD to know what his cholesterol was. right? Other physically tasked people have taken much better care of themselves than surgeons do. You know, again, I don't want to be their Mary Poppins and, you know, drag them around, having dangling from my apron strings, right? But
have to be able to see what we're doing, right? I mean, a lot of what we're doing is visual. I mean, if you especially in surgical training, like you have to be able to see the structures. I mean, it's released annual eye exams, which are recommended, and you know, we don't need to send them to primary care necessarily every year, but as you said, the stakes are higher. Like we are taking care of people. We're not quite pilots in the air, but like at the same time, we are with someone who is you know, under anesthesia or has their life in our hands.
No question. I leave it to them as professionals. I give them the checklist of things that I want them to do. I think they ought to do, that they agree upon, you know, come up with a pet care plan among them. And the residents are meant to take care of that on their own. You can tell when the residents are thriving. You know, you say, how you doing? Are you accomplishing the things that in life that you want to be doing? Because they're doing okay on their rotations. Their in-service scores are good. But then the resident says, yeah, I mean, I've been running 3 times a week. And if you can get a resident to get their life in order, so much so that they can run or exercise on a schedule, you're doing well, right? Because so much else has to be in order for that to take place. So I don't mandate it, though. You know, you'd never see a college athlete or, you know, an Olympian or someone else who's charged with a significant physical task be able to get by with the level of physical neglect that surgeons do. Well, thanks for your time.